So it's wonderful to be here at this conference. I'll just say my greetings while I wait for my slides to come up. But it's really fantastic to be in a conference about the leading technologies for TB diagnosis in Africa, right? I think too often these conferences are in the global north. So that is really a fantastic initiative. So my thanks and my congratulations to the organizers. So I'm going to be talking today about recent developments in TB testing and screening technologies. This is a highly fluid and highly dynamic, fast-moving area, but I hope that we can have a stimulating conversation. And as you'll probably see, there are many more questions than answers, but the future is probably brighter than it has ever been in terms of new ways to diagnose and identify people affected by TB. So as a statement of interest, these are forms of support that my research group, not myself unfortunately, has received. So I'm based at the Stellenbosch Medical Campus, which is in the city of Cape Town, South Africa, and it's a beautiful, very wealthy city, but it's also an extremely unequal city, right? So about 20 minutes from that previous picture, you have these highly urban, very dense areas where about 1 to 3% of people living in those communities have bacteriologically positive TB at any one time point. My group recruits from the clinics on the left in the northern suburbs of Cape Town, and that is where some of the data that I'll be presenting will come from in addition to the literature. But another big source of data that I'll be talking about is from an, until very recently, NIH-funded consortium called the RTD2 network, which spans the countries that you can see in that map. So TB is a massively underdiagnosed disease, right? Each figure here represents 50,000 people. And in 2023, almost 11 million people were thought to have got TB, and 1.25 million deaths occurred. 400,000 people identified developed drug-resistant TB. However, only about 8.2 million people were actually diagnosed and notified. An estimated 2.7 million people remain undiagnosed with TB every year. And crucially, less than half of the people who we diagnosed with TB were diagnosed with a WHO recommended molecular rapid test for TB. 4.3 million people were diagnosed, but they did not receive a technology that they should have. In other words, they were typically diagnosed with smear microscopy. In terms of the focus for the talk, I'm going to really focus first on this blue box where there are opportunities for non-sputum screening and confirmatory tests to reach the 2.7 million people that remain undiagnosed, as well as new sputum-based tests, primarily for the 4.3 million people who are successfully diagnosed but received an outdated technology that has significant limitations associated with it. So I first want to start this talk by talking about some fundamental concepts in TB, which are really crucial when thinking about how to optimally deploy new diagnostics. So we know that about half of TB is subclinical, and actually in the Namibian TB prevalence survey, exactly 50% of the TB they identified was in people who did not meet the WHO symptom threshold. I want to emphasize, however, that at least for 3 or 4 years now, I believe, the WHO has had in place recommended approaches using commercially available biomarkers as an alternative to symptoms. So for example, C-reactive protein, which is a relatively cheap test and which is very widely available, has been recommended as an alternative to symptoms by the WHO for at least 3 years. But we've seen very poor uptake of it, and this is a bit of a mystery to me. So I really want to touch on some of the implementation issues as to why we are not doing better with current tools that we have available. One can easily imagine a scenario, for example, where people with HIV who are already giving blood every year for their viral load monitoring could automatically have their C-reactive protein tested. This is an approach that is endorsed by the WHO and has substantial evidence to support it. The other fundamental concept, which, like all things in retrospect, is sort of obvious when you think about it in hindsight, but is the point that less sensitive tests can diagnose more people with TB if that test can be done in more people. So this is the concept of diagnostic yield. And on the left, for example, we have a test with 90% sensitivity, but it can only reach approximately 25% of patients. And you can see that that green square is relatively small on the left. And on the right, we can have a test with less sensitivity, 70% sensitivity, but you can diagnose far more people represented by the much larger green square. So in the past, I think we have been potentially arguably too strict with diagnostic technologies and somewhat obsessed with sensitivity. But higher sensitivity does not necessarily mean more people are diagnosed. So with many of the more accessible tests that are on the horizon, they are potentially not as good as sputum-based tests, but they can be done in people where sputum cannot. And when you have nothing, something is better than nothing. So this is especially important where there is the issue of sputum scarcity, right? Which is either an inability to make good quality sputum, or people are not willing to make sputum for reasons of stigma. This is something that's generally underreported in research. In prevalence surveys, salivary sputum, which is traditionally thought of being inadequate quality to be microbiologically useful, is especially common in people with HIV, children, and sorry, there's a typo there. That should be people with early stage disease. In our data from Cape Town, when we look at people who are very sick, who are self-presenting to the clinic, about 18% of those people cannot make sputum, which the laboratory considers acceptable. And crucially, this is a problem which is only going to get bigger because we are quite rightly expanding TB diagnosis to people with earlier stage disease. And in household contacts, for example, 43% of them in a study in Uganda who were symptomatic could not make sputum, and this was as high as 85% in asymptomatic household contacts. And this is highly variable for reasons that I'm happy to talk to you on the sidelines about, as summarized in this nice graph that shows sputum scarcity and salivary sputum across different TB prevalence surveys. The other fundamental point I really want to make is that the old way of doing things, where we rely on people to come to the clinic when they feel sick, will never be enough. Each year, 40% of incident TB is thought to never enter facilities. If you are fortunate to come to a facility and be diagnosed, people have transmitted for a median of 2 years before they are identified passively. And this reason, this dependency on passive approaches, together with the dependency on symptoms, are core reasons why we have not reduced population-level TB incidence. And in fact, in the literature, the only studies that have successfully reduced long-term TB incidence are those that have done active case finding and have done so regardless of symptomology. And if we think about this on a conceptual basis, diagnostic strategies that are symptom agnostic and are active rather than passive can result in more transmission averted. One of the last fundamental concepts I want to briefly touch on is that we haven't really thought adequately about what do patients care about, right? Which is kind of mad when you think about it, right? So in R2D2, we did some discrete choice experiments to ask patients across 5 different countries what was the relative importance they attached to different test features. And we wanted to assess if participants were willing to trade lower accuracy for more desirable test features. This was a big study. It was in over 1,000 people. One caveat, however, is that this was in classical TB patients who were coming to the clinic with symptoms. And on the right, you can see the type of questionnaire that people were given, where different scenarios are A/B tested. So what attributes do patients favor the most? So people in different places favor different things, right? Accuracy and cost were typically what patients considered the most important. And to our surprise, sample type was one of the least most important characteristics that patients identified. But keep in mind, this is in people who generally could already make sputum. And there's some interesting country-to-country variation there. And when we specifically asked which types of specimens do individual patients prefer, we found that overall, in this particular cohort, most patients had a mild preference, or the highest preference overall, for sputum, slightly ahead of other interesting technologies, such as oral swab technologies. But there is country heterogeneity here, right? So in India and the Philippines, oral samples were preferred by patients, whereas in Africa and Vietnam, sputum tended to be most preferable. Now, I want to say this is a very blunt exercise. I've shown you averages, right? Even within a country, different types of people prefer different types of tests, right? So for example, people who are very, very sick or know someone who's died of TB, they just want the best possible test. They don't care how invasive the sampling is, how uncomfortable it is. People with very early stage disease or people who do not feel sick want something quick and easy and are willing to sacrifice sensitivity in order to be able to get a result quickly. And time to result was actually one of the only test attributes that people were willing to trade in order to reduce accuracy. So I'm going to now quickly dive into technologies that could meet these fundamental needs that I've summarized, and I'll just repeat it on that slide. There's not enough time to exhaustively address all the available technologies, but I've focused on those that are already on the market or shortly will be, especially those that have beyond proof of concept data and ideally some form of external validation, and have at least the potential to be applied at least near the point of care. So this is the TB diagnostic pipeline done by these consortia in the top right, and this is for next generation antigen tests. And I really want to just highlight how in the right column, and especially the bottom right corner, there is a bit of a dearth of technologies. The technology pipeline still remains relatively poor, and we need more innovation in this space. The same is true for molecular diagnostics, which are needed for confirmatory TB testing. The pipeline is a little healthier, but we really have very few near point of care or point of care solutions on the horizon, unfortunately. And what we know historically is that there's very high attrition along this pipeline. Many things do not make it to the next phase. One of the most important screening tests that the Honourable Minister spoke about, and it's fantastic to hear that it's been widely adopted in Namibia, is chest X-ray with computer-aided detection. This is one of the most sensitive screening tools available for TB. And chest X-ray as a technology is itself globally underutilized due to shortages regarding radiologists and infrastructure. Importantly, this is technology that has been WHO endorsed for years. It's a fast-moving field, but there's still a lot of work to be done, even though these technologies are ready to be used, to develop appropriate thresholds in special patient groups. So for example, the algorithms have been developed for people primarily coming to the clinics. Special groups like children or people in communities may need different algorithms developed, including people with previous TB. There's also unexplored potential to combine these algorithms in conjunction with clinical and patient metadata. So for example, algorithm performance differs in women versus men, typically. But we haven't really looked at holistic approaches that incorporate that data to develop individualized risk scores for TB. So in R2D2, we did a head-to-head comparison of the leading commercial computer-aided detection algorithms. And at 90% sensitivity, specificities ranged from 65 to 74%. Not all algorithms were equal. CAD4TB at this sensitivity had overall the highest specificity. However, all algorithms had their accuracy compromised in people with HIV as well as people with previous lung damage. Crucially, there remains very little data in children who have very different radiological manifestations of TB disease. And for this reason, the WHO endorsements only apply to people over 15 years. However, I know several companies are looking to address this issue. This is an additional comparison where we took the best performing CAD algorithm for TB diagnosis and we compared it to the GeneXpert host response cartridge, which is a host RNA signature cartridge, as well as to C-reactive protein. And CAD and Expert HR had an AUC of close to 90%, and CRP was not far behind, which is not bad for a test that is dramatically cheaper, certainly probably dramatically cheaper than expert HR. So this just goes to show that there are many different ways to achieve in similar diagnostic accuracy depending on the local context. I'm not going to go into this in detail because I believe there's a speaker on this topic later, but another digital technology that is extremely exciting is cough sound classification to triage people, rather to screen people and prioritize them for TB diagnosis, where you get high areas under the curve, but there is geographical variation here. Crucially, this also appears to be important for treatment response monitoring. If you look at the figure on the right, you can see the cough count trajectories of people on treatment who have a bacteriological positive result. That's the red line. They have a very rapid decrease, as well as people who were diagnosed empirically who have a green line where they have a slightly slower increase in cough count. And this is all done using smartphones. Other really crucial diagnostic tools that are exciting and are on the horizon is AI-enabled point-of-care ultrasound, as well as vibroacoustics. And one of the most promising technologies is done using this device that's the size of a Coke can, roughly. It's made by Level 42 AI. And when we evaluated this in several African sites where you do the sweep of the torso, we found a surprisingly good area under the curve of 0.86 and high sensitivity and specificity. It's not quite reaching the optimal WHO targets, but another very interesting feature of this technology is that it appears to be very good at differentiating people who have severe versus non-severe disease. And this is obviously crucial because TB regimen shortening is a key priority, and being able to identify which patients do or do not need longer regimens is an important research priority. So moving on to confirmatory tests, so away from screening tests, I'm going to briefly talk about face mask sampling. This is a type of sampling which on a very practical basis, I believe is easily implementable. So in Cape Town, where I'm from, people start queuing the night before outside clinics in order to get clinic access, right? Clinics see a set number of people every day, and if you are, for example, number 100 in that queue, you're just not going to get seen. So people are congregated tightly for hours, right? These people could wear face masks, for example. These are early prototypes showing a face mask which not only reduces aerosol spread, but contains a collection device within the mask. And these collection devices generally capture more bacteria the longer they are worn, although it tends to plateau after approximately 1 hour. So we've been working with a Swiss company called Avelo and have been optimizing their face mask. This Avelo mask prototype has 73% sensitivity and very high specificity in people who are symptomatic. I seem to have lost the picture on the front here. Thank you. And of course, this performs best in people who have high sputum bacillary loads, but has the advantage of being able to be worn for a very long time. So one can easily imagine a scenario where people are queuing outside the clinic, they're in the queue anyway, they probably should have some form of respiratory protection, and that form of respiratory protection could also actually serve as a diagnostic substrate. Urine lamb tests, we are almost upon the third generation of urine lamb tests. This is one company that has one of the most promising technologies. It's called Biopromic, and what their sort of special ingredient is that they have a capture mechanism by which from high volumes of urine, it's very easy to concentrate the urine lamb molecule and do that in a point-of-care test. And what's really exciting about this method is that it also reduces inhibitors. So if, for example, you compare readouts with and without the removal of inhibitors represented by the orange and the gray bars, you can see that with the gray bars, you get a much bigger signal boost once you've removed these inhibiting compounds in urine. This test is vastly superior to the first generation ELIA lamb test, right? This is work by Dr. Anna Ojo in my group. And we found 66 to 62% sensitivity, both in HIV positive and HIV negative people. That is a group in whom urine lamb testing was traditionally not considered worthwhile. This is a very rapid test, and you can see the sensitivity is at least double what the Lee lamb test is. I should also point out that these are people in primary care. These are not people with advanced disease who are coming to a hospital. There's a wave of other urine lamb assays coming. In this very nice slide from FIND, we can see that these span different levels of needing equipment, right? There are Chinese and Korean companies that are developing lamb tests that do not need a reader, some that do need a point-of-care reader, and then some that need a point-of-care reader, and importantly, like the biopromic test, include a specimen concentration step. Those are the ones that I think are potentially the most promising, but we need more data, especially from children. So a very exciting alternative for confirmatory tests that is rapidly emerging are tongue swabs. So I think of the tongue biofilm as really just being a filter because people with TB are producing drops of sputum that pass over their tongue throughout the course of the day. And approximately 80% of the biomass in the oral cavity is actually on the tongue, right? The tongue is covered in microbes, and TB is able to become resident on the tongue. So after a lot of initial early validation work, we now have fairly conclusive data emerging about the utility of gene experts on tongue swabs. This is data across these consortia partners on the bottom, where a consensus protocol in 1,700 people in 8 countries was used. And yeah, tongue swabs at 66% sensitivity and a specificity of 99%. Now, crucially, there's still a lot of optimization to be done in this space. Lauren Rockman at Stellenbosch has shown that oral washes, where you put water in the mouth and you swirl it around, can outperform tongue swabs. We know that some types of tongue swabs, such as a foam versus a flock tongue swab, boost sensitivity. But the most interesting thing that she showed is that you can do a tongue swab in people who have sputum-scarce disease, and 18 to 25% of those people, depending on the type of tongue swab, or depending on the type of oral swab, or oral sample rather, 18 to 25% of those people, even though they cannot naturally make sputum, are tongue swab positive. And this almost doubles the yield compared to sputum-based testing alone in a scenario where sputum induction is unavailable, which we know is the programmatic standard of care. Now, things are only going to get more promising with tongue swabs. There are exciting purpose-built tongue swab platforms that are shortly coming on the market. One of the most important ones is from China. It's called PlusLife, and you can see in the bottom right corner there the data both in terms of error rate, sensitivity, and specificity of PlusLife on tongue swabs compared to Gene Expert, and the MTB Ultima product from India is shown. And sensitivity there is approaching 90%. And there's another key thing I really want to emphasize here, is that these platforms can also be done on sputum, right? Because if someone can make a sputum, you should test the sputum. Am I okay for time? Yeah? 2 minutes? Okay, I'll pick up. And there are many more commercial platforms that are rapidly emerging, mostly based on COVID-19 technologies, and the majority are coming from Asia. Crucially, a lot of these new technologies open up exciting opportunities for in-home testing, right? This research done in the Eastern Cape province in South Africa shows that if you take a diagnostic test into the home, people trust it more, especially if they do not feel symptomatic yet. If you see a sample come from your own mouth into a machine in front of you and you see that result become positive, you believe it much more. And this translates into improved linkage to care and uptake of services. Now, this approach used only sputum, but when you add tongue swabs, you, again, approximately double the diagnostic yield. So in conclusion, diagnostic inequity is still a very real issue, both in children and people with HIV who suffer the most. To make the case for non-sputum-based tests, we need better information about sputum scarcity. I really encourage you in all of your research, this is such a basic concept, but it is shockingly underreported, ask every person to try and make a sputum naturally. Document if they can do it, and why not. Record the quality of the sputum. And please do not only evaluate non-sputum-based tests in people who can already make sputum. My other point is that non-sputum tests, despite their lower sensitivity, can have similar or better yield to our best sputum tests. And urine, tongue swab, and digital technologies all hold tremendous promise, as do many other tests that I've not had the time to speak about. Some tests, like host RNA signatures, are having some of their allure diminish as research, more independent research emerges, but they may have important niche applications in important subgroups such as children and for predicting future TB. Even though I've spoken about non-sputum tests a lot, please do not forget sputum. If someone can make sputum, it should be tested. And please remember that all tests need to function in dysfunctional health systems, but we cannot expect a diagnostic technology to itself fix a health system. We need data on impact of yield-based strategies where accuracy is less important. And we also need to think about the utility of negative test results. Negative test results can mean that that person can start TPT. Many risk factors for TB are also risk factors, are also indications for starting TPT. But the biggest challenge is first ruling out active TB, which new diagnostics can help with. And technologies will improve in time, but we have enough technology now to start making substantial inroads. And with that, I'd like to thank the organizers and everyone else on the slide. Thank you.